Hi everyone. Good morning, good afternoon. Welcome to today's webinar. We're just waiting for people to be added into the meeting, but we have lots of attendees already, which is really great. So I just want to start off and welcome everybody. So welcome to today's webinar to mark Universal Health Coverage Day 2025. Today we're considering who gets left behind in urban contexts and how we can address health vulnerability and equity in those contexts. We've got a nice full agenda for today. So we're going to start with some presentations. We've got presentations from each of our chorus partners who are going to give some insights from their contexts and some highlights from the research that's underway in each of those contexts. We'll then turn to our expert panel for some further discussion on the issues. Just a little bit of housekeeping. We are recording the session today. That's so that we can make it available afterwards, and we will be in touch to follow up with some additional resources if that's of interest to attendees. Hopefully you can see at the top of your screen there's a chat box and there's a Q&A box. Please, if you have questions for our presenters or our expert panel, please post questions in the Q&A box. If possible, we will get to those and direct them to our expert panel at the end of the session, but we have got quite a packed agenda. So if not, we will use those and follow up to share information after the session. I hope that sounds okay. So I think, given that we've got lots to do, lots of exciting things to discuss today, I think we should get straight into it and start off with presentations from each of our presenters. So we've got presentations from Nazneen at BRAC, Nabila at ARC Foundation, both of those in Bangladesh. Then we have a presentation from Dominic in the University of Ghana, Aloy from HPRG at the University of Nigeria, and Sampurna from Herd International in Nepal. So I'm going to share the slides. Just a reminder to everyone presenting, please try to stick to about 4 minutes each, because we want to make sure we've got plenty of time for discussion at the end. Sorry, I'm on the wrong slide here. This is what you get for trying to multitask, speak and share slides at the same time. Okay, so I'm going to hand over now to Nazneen.
Thanks, Barney. Am I audible?
Yeah. Yes, go ahead.
So hello everyone, this is Baby Nazneen from James Speaker School of Public Health. It's wonderful to be here today in this presentation. So I, along with some of the chorus colleagues, will share our work related to urban poverty and vulnerability across Bangladesh, Nepal, Ghana, and Nigeria. So for my part, I will specifically focus on the work we led at James Speaker School of Public Health. So our work mostly were related to identifying and understanding who are the urban poor and vulnerable populations, and also understand their health related challenges. So yeah, next slide please. So the aim of our work was to mainly generate actionable and precise evidence for the policymakers to design equitable health interventions. So for that, within our research, our focus was related to two vulnerable groups. So one is like slums and residents of slums and informal settlements, as well as what we refer to as invisible poor, the low income population groups living outside of slums. So this particular group actually gets overlooked as there is common understanding that poor people live in the slums, but in reality, the pocket of poverty actually exists across the city. So they are also available in affluent areas as well. So these groups face different kinds of inequities, including economic and income disparities, as well as health-related, accessibility-related barriers, climate and environmental-related risks, such as extreme heat exposure. These kind of things they face. And also in terms of key barriers to healthcare, we often know that these vulnerable groups of population has heavy dependence on informal providers like pharmacies, which leads to high out-of-pocket expenditure. And there are different kinds of government and NGO efforts to address these kind of challenges. However, since there are rapidly growing urban population, so there are it's quite challenging to address this challenge. To reach everyone, especially to the deprived pockets where these groups live. Next slide, please. So we used a combination of methods to identify and reach these urban poor or vulnerable groups. First, we are using small area estimation technique, combining household income and expenditure survey data with population census data to produce ward level poverty maps in Dhaka city. We are also working to validate these estimates through household survey in the poorest wards. Besides, we also conducted a heat vulnerability mapping in Dhaka city with primary data from 65 plus monitoring sites, as well as we used satellite data. So this helped us to identify the heat vulnerable areas within Dhaka city and to understand their health related impacts due to heat exposure and their coping mechanisms. We also conducted a discrete choice experiment to understand with informal settlement residents to understand what they value or what their preferences are related to primary healthcare services. Next slide, please. Next slide, please. So basically our estimation, this micro level estimation helped us to get much clearer and micro level picture of urban health inequity, because this kind of mapping or this kind of poverty estimation technique was not actually quite popular in earlier national estimates or earlier research work. So this gave us an clear understanding of who is left behind and why. Besides this, our work actually gives us a stronger basis for pro-poor targeting, so that government, development partners or NGOs can focus on those areas, prioritize the vulnerable population, and design their intervention for those. And besides the clear understanding from the DCU work, we got clear understanding of what people value in primary care. Next slide, please. So overall, from our work, there are few actionable recommendations. So we recommend that the policymakers and other stakeholders to integrate this kind of data-driven techniques for resource allocation and urban health service delivery planning. Besides, while designing this kind of interventions, they should they should use this kind of evidence that what urban population groups actually value regarding the services. So they should co-produce and work with these groups of population in all level of planning. So with that, I will end here. I will hand over to Nabila Apu for the next section. Thank you.
Thanks very much, Nazneen. Nabila, I think, was just having some technical issues. Is Nabila now joined? I think she was joining on with Rafi. do we have Nabila? Okay, in the interest of time, perhaps we can go to the next presentation and I'll come back to Nabila if she's able to join shortly. So can I hand over to Dominic, please? If you're there, Dominic.
Yes, thank you. And I hope I'm audible.
Yes, please go ahead.
All right, good. Good morning, good afternoon, good evening, everyone. And so I'm Dominic. This morning from Ghana, I present what work Chorus Ghana is doing. Basically, we are looking at how best we could link communities, local government, and health workers to support life cycle health promotion and preventive health services at the community and household level. And so it's key to know that we are not leaving anybody behind. And so we were strategic in our study site, selection. Next slide. And so we looked at study site that is highly urbanized, very densely populated with varied population dynamics. And so we identified key vulnerable population in this urban community that we sampled our data from. And so we found basically that these are slum dwellers. About 62% of the population that we really, engaged for this study are slum dwellers. And basically these are people who migrated from other parts of the country to this part. And mostly they are from the northern part of Ghana to the southern part. And so they live in urban slum structures in these various study locations that we considered for the study. And so because these are internal migrants and because of the population growth among this group, they actually do not have well-structured home to stay. And so you see most of these dwellers stay on the street or sleep in shops and other homeless structures, let me put it that way. And so these are homeless persons. And so majority or most of the youth amongst them actually engage in substance use. And so these are the vulnerable groups that we identify from our study population. And this is very key because we don't want to leave anybody behind, and we don't want to leave this group of people behind. And so what are the barriers these people face? We found that only 54% of the population actually are covered by the National Health Insurance Scheme, and making it quite difficult to access healthcare financially. And so that's a key barrier. And so through our engagement, we also realized that there is the poor local government involvement in health decision-making in the municipalities that we engaged. And so the assemblies and the local government structures at district level are less involved in decision-making when it comes to health in the municipality. And the other key barrier is that the urban PHC in these localities, urban area, basically the services are provided in silos. So there's a fragmented PHC in these localities. And so making it difficult for people or this urban vulnerable population to really access the services, the health services that they really need to access. So next slide, please. All right, so how did we identify this vulnerable population? First, we went back to ourselves. We reoriented ourselves, we retrained ourselves, basically to understand participatory action research. How can we value the active participation of the communities, the community structures and all that? How can we conduct effective community engagement or community entry and even be able to identify who vulnerable population or groups are? And so through this training, we were empowered. And so we started from the district level, and then one closer to us, basically because research and health. And so we rather went straight to the district health management team to support us in the identification of these various populations. And so what did we do? Through the district health management team, we were able to identify the community structures. And these are the various groupings within the urban context that we're looking at. And so we have associations like Association of Hairdressers, barbers, market women, and so forth. So these are major community structures, as well as the chiefs and the assembly members in the various communities that we want to engage. And so through the district assembly, the district management team, we were able to identify these various structures. And so after this identification, what next? We needed to really interact, engage these people. So let's go to the next slide. And so through collaborative relationship, we were able to engage these various structures that we identified in the communities. The communities, the health workers, and the research team then sat down to, first of all, develop what we call the rich picture, which is shown on the left, basically to understand what are the physical structures available in these various urban localities that we are considering. The health facilities, the marketplaces, the population, where do they sleep, and all those various physical structures. Where are they located, the road network, and so forth. So we came up with this true collaborative relationship with the various groupings that we had. And so after this identification to the rich picture of the physical structures, we then went into the community to do effective community entry. And so we started with the assemblymen in the various communities after our interaction with the district level management team. And so it made it quite a bit easier for us to be able to have this engagement. And so you can see the picture in the middle, how people are actively involved because of the effective community entry that we were able to conduct. And so the people were quite involved and in what we were proposing, the solution that we had to co-create together, the challenges that they were facing and all that. And so they were able to bring all these issues to bear for us to be able to develop the intervention that will meet their needs at the community and the household level. And so next slide. And so through this, we realized the active participation of the community. We realized the active involvement. We realized that the people are now more aware of the health issues confronting them and where to access the services, what type of services, what should they do, and so forth. And so that brought a lot of interest to health. And so from this picture, you can see how active the community members are. The various groups, you can see the fitters, the drivers, the various groupings all wanted to be part of our brochure, our flyer for the health promotion activity for our intervention. And so that's how involving and the communities were actively in the study and now more active in taking their own health into their own hands and knowing where to access the health services and so forth. So we are not leaving anyone behind. And so this was the whole concept. And this was what we obtained, and the improvement that we've seen, that there's that intention to utilize the services instead of going to herbal, instead of going to other places. And so basically we've seen a lot of improvement with this community of vulnerable population in terms of our study. And so let's go to the next slide, please. With this, what are the key recommendations? So I'm taking you back to the barriers that these vulnerable groups face. Basically, we are looking at the services which are provided in silos. And so there's a need for an integrated service provision. And so we're thinking through Ministry of Health and the Ghana Health Service, if they could strengthen the PHC pathway, that would be very helpful for this population. And so, for example, through the urban networks of practice, that would be very helpful to be able to increase the coverage of the services and the quality of the services that this population can obtain from the various facilities. In terms of the the multi-sectoral collaboration, we also believe that because of the weak or poor engagement collaboration among the various structures and the sectors involved, if we could strengthen this, because in Ghana, for example, we have different agencies and ministries which can come on board with regards to various health actions for this vulnerable group. For example, the Ministry of Health, the Ministry of Gender, Children and Social Protection, under which we have LEAP, Livelihood Empowerment Against Poverty. And most of this vulnerable population can fall within, and this population can be registered or linked to the Ghana Household Register and automatically be linked up to the National Health Insurance Scheme, so they can have access financially to the health services. And so there's a need for the National Health Insurance Authority to also increase or scale up coverage of the scheme to this vulnerable population. We believe through this recommendation, if effectively implemented, this urban poor population will be able to have access to the quality health services they deserve, so nobody will be left behind. Thank you, and over.
Thank you very much, Dominic. As we missed Nabila, let's go back and hand over to Nabila now, and then we'll come to you next, Aloy, if that's okay. So Nabila, over to you.
Thank you so much, Brandy. Good afternoon, everyone. So I'm Nabila Binte Jahan, and I'm working as a senior research assistant at ARC Foundation. And from our side, from data to impact, advancing gender equity in urban slums of Dhaka city, I will present about our work as efforts towards universal health coverage continue. Certain groups remain consistently excluded from primary healthcare services. Among these, third gender individuals, commonly who are known as Hijra in Bangladesh, are particularly marginalized. Although legally recognized as a separate gender in 2012, this recognition has not translated into meaningful social or economic opportunities. Many members of this community sustain their livelihood through informal work, begging, performing traditional rituals while childbirth, or engaging in sex work. The government has initiated programs to reduce these gaps, notably the Livelihood Development Program under the Social Safety Net, to meet the SDG 3 by improving financial security and reducing barriers to essential healthcare for this group. The challenges persist. Hijra individuals face multiple barriers while seeking healthcare services, including the high out-of-pocket expenditure, stigma and poor treatment at healthcare facilities, and lack of representation in health data. Also, the financial vulnerability due to social and economic exclusion. Next slide, please. To address these gaps and to identify these vulnerable groups, we conducted key informant interviews with the policymakers, in-depth interviews with the healthcare providers of urban primary healthcare centers, CAP meeting with the community members, and patient exit interviews with both male, female, and also the Hijra community. Next slide, please. To what we have achieved through this project. As you know, that our core objective has always been to ensure all individuals, regardless their gender, socioeconomic background, and education, have equitable services to healthcare, particularly for the management of NCD care in Bangladesh. To achieve this, we focused on strengthening healthcare providers' capacity to follow the National Protocol for Diabetes and Hypertension Management, ensuring the services are delivered without discrimination. We also advocated for the health needs of the third gender communities during the conversation and coordination meetings with the Ministry of Health and the Ministry of local government, those who oversee the primary healthcare services in Dhaka city. As a result, we successfully worked with the Simple App developers and the Ministry of Health to integrate transgender individuals into the system, and which allows the ministry to oversee the NCD data of the Hijra community into their national dashboard, and they can which can enable the real-time monitoring of the NCD services, and who are previously invisible in the national health data. So, previous slide, please. And additionally, we are also developing a guideline on strategic purchasing that will include a dedicated service package to address the healthcare needs of the third gender individuals. And previously, from our Chorus 2 project, we directly collected the data from the community members of the Hijra community and which gaps they are faced and which barriers they have faced while seeking healthcare services from the facilities. Next slide, please. And as we are moving closer to achieving the UHD, several pathways are essential, like reducing the stigma and through engaging the community members and to avoid the healthcare facilities due to stigma, fear of mistreatment, and being turned away. And changing community attitudes is a critical first step, as we know that the third gender individuals always face the stigma while seeking the healthcare services into the from the primary healthcare facilities, as most of the community members get feared by them after seeing them, that why they are here. So to address these gaps, gender sensitive training can also be helpful for both the policymakers and healthcare providers, so that they can include that third gender into the system. And another one is to ensure and identify the ways to ensure that third gender can avail the services. Previously, Professor Irene has shared her insight in a meeting that in their community, sex workers were successfully included in health system by offering services in dedicated days when other members or other genders can give them a space to seek services from there. So this can be included in Bangladesh as well. And our ultimate goal is simple: to ensure that those who are left behind can be included, and they deserve to be counted, and they deserve to be counted to access the service they need, and that will cover the UHC for everyone. Thank you, everyone.
Thank you so much, Nabila, and apologies for the slight issue with the slide change in there. That was really interesting. We're going to turn now to Aloy. Can I hand over to you, please?
Hello, everyone. Sorry, my audio is not so great. I'm currently at a workshop. My name is Aloy Shisudi, and I'll be here to present some of the findings in our research in Nigerian slums. But essentially, the study is about trying to link the informal healthcare providers in slum to the formal healthcare system. Next slide, please. So in our attempt to link the informal healthcare providers to the formal health system, what did we find? We discovered that our project was very interesting, more especially because there were indeed a lot of vulnerable people, and that also motivated us to think through how we can make more impact in our project. For instance, the area, like I mentioned before, is a slum. And because it's a slum, we are basically dealing with a good number of urban poor persons who are engaged in our project. And for this reason, it was a bit difficult for these poor urban health residents to access the services that are being provided at these slums that they reside in. More especially, we find that women, and especially pregnant women and children, are much more affected because they rely on traditional birth attendants and the patent medicine vendors for care. Although we can argue that there are lots of cultural connections to the reliance on TBAs and PMV, but we can't also rule out the fact that a centerpiece of it is the financial concern. Because at the later stage of our project, we had instances where we recommended some of these women to, or rather where the informal health providers referred them to formal health system, and they refused to go because of financial concern. So also interesting is the fact that we have youths who are a bit nonchalant and difficult to engage when it comes to healthcare. in a different project, we are trying to explain how that is also linked to masculinity and how men especially see themselves, with regards to accessing healthcare. So within these same slums, there were also disparities in the sense that some slums have functioning facilities, while some does not. So that also creates a sense of vulnerability within those slums that do not have access to primary health centers. Next slide, please. All right, so because of all of these issues, we discovered there were a lot of barriers. As explained earlier, the barriers are majorly driven by economic concerns. The people we are dealing with cannot access care because they do not have the money to pay for healthcare. And then we find that because of that, like I said earlier, they were a bit more dependent on informal health providers. But interestingly, there were also some social gender dynamics. For instance, even though the women were a bit more exposed to the intervention or the linkage, we find that financial concern makes it difficult for them to make autonomous decisions about their health. But again, we can't also rule out the fact that the primary health centers in some of these slums were a bit, I don't want to use the word abandoned, but when you compare them to other health centers in a much more urban area, you find a lot of difference in terms of the number of healthcare providers that work there, including functionality. I have to just say, there are instances where a good number of the facilities are closed, they are not working. So that was also a barrier. Next slide, please. So what did we do in our attempt to solve some of these problems? First of all, our study was essentially a participatory co-design approach. That is to say, we are very careful in trying to bring in people to help us identify those who are marginalized. In this case, we engaged the community leaders, we engaged the informal health providers, we engaged the primary health care workers, as well as the community members. So we've been engaged, even as I speak with you right now, at the workshop that we're engaging, that is ongoing behind me. It's also an engagement with the community leaders, sharing our findings, trying to make them understand what we see, and then they make suggestions on how to better reach the unreached, if we want to put it that way. So again, our approach again also involves trying to strengthen the relationship that currently exists between the informal health providers and formal health providers. Because initially, before the intervention, it appears as if there is this tension, this conflict. The formal health providers see the informal health providers as quacks, people who are not fit to be within the healthcare. And that was a big challenge. But at some point, through engagement, a good one, if you ask me. And finally, our project has led to the establishment of the Urban Health Unit and the Ministry of Health here in the state. So the Urban Health Unit has a role to play in terms of trying to create a linkage between the informal health providers and the formal healthcare system. So that's also instrumental, because now we are trying to see if we can leverage the Urban Health Unit to reach out to more informal health providers in the slum, provide training, capacity building, so that they will be able to provide health care for people in slums. So let's move to the next recommendation, please. So finally, our recommendation would be there's a need for us to continue to strengthen and resource primary health centers in slums, because even if you encourage the informal health providers to refer people, instances where they refer people to primary health centers and the healthcare providers are not on seat or absent from their duty, that's a challenge. It doesn't help us achieve our goal. Moreover, instances where they do not have pharmaceuticals or other medicines, they would have used to attend to care. If they don't have it, they still will not be able to meet up with the project demand. So that's also something that needs to be addressed. And then again, we need to completely institutionalize and scale the formal and informal provider linkage. At the moment, we're barely dealing with Enugu, which is just a state in Nigeria. There's so many other states with a lot of slums, that also needs to be paid attention to. But we also need to pay attention to the economic barriers, because in as much as we want to improve access to healthcare, the socio-economic conditions of the residents is also a challenge. We need to start thinking of whether insurance packages that somehow targets the poor or things like that. And finally, the informal health providers continue to need capacity building exercises, because we believe that for them to be partners in the healthcare provision, we need to be able to continuously build their capacity to do so. So thank you very much for listening to our findings.
Thank you so much, Aloysius, and thank you for joining, even though you're doing another webinar in the background. I'm going to hand over to Samperna now, and we're a little bit over time, Samperna, so just please encourage you to stick to the time if possible. Thanks. You're on mute, Samperna.
Yeah, can you hear me? Yeah. Yeah,
yes.
Hello everyone. Thank you, Briony, for this webinar, and thank you everyone for joining this session. So I will share about the urban health inequality in the context of Nepal, what we learned from the CHORUS project, and what it means of achieving the universal health coverage. Next slide, please. Next slide, please. Oh, there.
Is it showing?
So this is so I'm sharing what we learned from the CHORUS project. So the major finding of the CHORUS project that we find. So can you hear me?
Yes, I think there's a slight delay, but yes, we can hear you.
Yeah, okay. Yeah, okay, thank you. Okay. The major lesson learned from the CHORUS project was that we find there is insufficient evidence of urban health, and also there is a lack of understanding on urban poor. So there is also lack of understanding in intersection analysis in the routing data. Public-private partnership are limited, and also there is no clear definition of urban poor in the national survey. And also there is a lack of data harmonization between different sectors within the health. So achieving universal health coverage in this context is important. It is necessary to measure the urban poor. What are the characteristics of the urban poor, and what are the health risks the urban poor deposits? So to address this gap, we have in our project we are going to develop the urban health data portal. So the major finding from the social mapping and the major finding from the household census will be integrated to develop the urban health data portal. This urban health data portal will identify the urban poor, what are the characteristics, and what are the risk waiver deposits, and this portal will also identify the address the health equality within the urban municipality of Nepal. So next slide, please. So this is the finding from the household census. We identify like 5.87% of the population in the urban municipality are poor. The definition of urban poor was based on the definition of the definition from the DHS survey only for the urban municipality, which was based on the various dimensions like not durable materials made of the roof, floor, and wall, not access to improve water source, no access to improve sanitation, and there is a problem of overcrowding. So by demographic outlook, we can find that urban poor are comparatively high in male population, adult age group, and they have possessed the primary education. And we also identify what are the health risks the urban poor poses. We find that there is a substantial prevalence of self-reported communicable disease and non-communicable disease, and also the prevalence of hypertension and obesity among the urban poor. So next slide, please. So to address the urban health equity, we just perform the concentration curve that measure the risk behavior across the different outcome by social stratifier. So actually this urban health equity measure the quantify the socioeconomic equality in obesity and identify social determinant contribute to that obesity. So when we see that the line, so various variables such as age, gender, and metastasis and education are lines similar to the line of equality. So we can conclude that there is no inequality exists. But however, when we see the concentration index of the ethnicity, we find that Dalit have higher blood than the straight line. So we can conclude that Dalits have some sense of inequality. And we also find that Dalit have higher risks of obesity compared to other group. So next slide, please. So for similar process, we also do urban health equality to measure the prevalence of hypertension across the different world contact by social stratifier. So in this urban equality analysis also, we also find that gender, age group, and occupation have similar level of equality across the level of equality, and we can conclude that no level of inequality exists in this group, but however, we can find that ethnicity, marital status, occupation have different curve compared to the line of equality. So we can consider this variable have high risk of inequality. So during we can summarize that Dalit group and the population who are never married and population who have no formal education have high risk of hypertension compared to another group. Okay, next slide, please. So this is the take-home message, what we deliver from the household census and also from the working in Nepal. We find that Nepal government have already in this urban debt policy and gender and intersectionality has been already considered in the policy framework. However, there is a lot of challenges. For example, equality is narrowed down, but there is still gaps in social determinants. And I already said before, there is a lot of data fragmentation and urban poor are not maximally measured. And urban health system also need to engage or reframe the private health sector. And this is the final conclusion is like government should promote the disintegrated data and enhance evidence-based planning so that no one is left behind. So next slide, please. Well, thank you so much.
Thank you so much, Samperna, and thank you to all of our presenters. I'm sure everyone will agree you've really demonstrated how inequalities and marginalised groups have been considered and identified within Chorus so that every subsequent project can really target those groups and take steps to address the issues. I'm going to hand over swiftly now to Shriman, who is going to lead the discussion with our wonderful expert panel. So over to you, Shriman.
Hello. Am I audible?
Yes, please go ahead.
Good morning and good afternoon to everyone joining us from across different parts of the world. It's my pleasure to welcome you all in this panel session. As you know, the title of today's webinar is Who Gets Left Behind? Addressing Health Vulnerability and Inequity in Urban Context. As we are holding this conversation just ahead of the Universal Health Coverage Day, that actually reminds us making some solid interventions to address inequalities in different cities. As our cities are growing quite rapidly, marginalized and unreached populations are facing more and more challenges in terms of healthcare. And today we'll explore how urban health system can become more equitable, resilient, and responsive. We're honored to have a distinguished speaker who are expert and leaders in health system, research, policy, and health interventions. Let me introduce our distinguished speakers. Our colleagues from Nigeria, Ghana, Nepal, and Bangladesh have already set the scene for the discussions. And let me introduce our panelists. We have Dr. Deepak Paudel, public health and health system expert from Nepal, who has extensive experience working with local government, health system strengthening and implementation research across Nepal and LMICs. Likewise, our another guest is Professor Zahidul QM, who Director of the Center for Excellence for Urban Equity and Health at Brak James P. Grant School of Public Health in Bangladesh. Prof. Zahid is a leading researcher in health economics, urban equity, and pro-poor health intervention. And next we have Said Masood Ahmed. Prof. Said is a director of the Center of Excellence for Health System at Brak Refugee School of Public Health in Bangladesh. And our another panelist is Dr. Osasui Drisu, who has joined us from Nigeria. Dr. Osasui is Executive Director of the Policy Innovation Center. She serves at the interface of public policy, behavioral science, and social innovation. And finally, we have Professor Peter Elias. He's co-director of the Center for Housing and Sustainable Development at University of Lagos, Nigeria. Prof. Elias is a prominent scholar in urbanization, social vulnerability, housing, and environmental justice. We are honored to welcome you all in this talk today. As we don't have much time for discussion, let's begin the conversation. First, I'll start from Prof. Zahid. Prof. Zahid, we have been discussing inequity for quite a long time, but who do you think are the most vulnerable individuals and community in terms of equitable access to quality primary health care? Would you please share your thought considering the urban complexities and access to quality healthcare in the context of Nepal, Bangladesh, or other LMICs? Over to you.
Thank you, Sriman, and thank you, everybody. Thanks to the Chorus project. They're organizing this, and of course, sharing all of their experience and what has been going on. So, yeah, that's a very important issue, like, urban context. But as if you say that, well, not only urban as such, who are the people left behind? And in that context, if you're saying that, what are the who are the people? They are not the most vulnerable in IMSC context. So we could understand that most of it is like we know that, well, in a sense, that the poor and the most disadvantaged population, like we have seen in the presentation, and we have also seen, and they are the most vulnerable, and particularly in an urban context, a large segment of quite a bit of a large segment population are really at the stage of settling down in the city. They have migrated. So, like, again, they are kind of floating population. We don't know exactly where they're living. So there are some examples that has been shown like today. So these are the two other things I have to really identify that. But again, if you really want to say that, well, do we know who are they? We have said that they are the people, but do you know where they live? This is another good example that the Bragg James Wigan School of Public Health try to find out. Even at the small area, we need to kind of say, identify where do they live. It's difficult. Again, the definition, and this is also another thing. How have we really defined the poor very well? Because if you don't kind of define them, they measure them. So that's another issue. We kind of really identify that, okay, who are the people? Do we exactly know them where to live, and how we have identified and defined that who are these poor and disadvantaged population? So, and I just would like to remind, just myself and others as well. So if you pick up the definition, which particular definition we stick to when we are trying to kind of an equitable inequalities and access to care. So I think Sampurna has just also gets to mention some of the interesting characteristics, and even those data, Sampurna himself was kinds of the work he's doing in Nepal context, that, well, we have picked up some population and picked up one health outcome and see that whether the concentration index that which shows the distribution. So that's an interesting way of really looking at. But again, one of the reason I try to kind of mention here is like, are we considering that, okay, are you just spending one particular health outcome, but can we really consider the equal access for equal need as an indicator for equity? And then can we really look at the data, really identify? So these are the things which I think would really, for the time being, to answer those questions. I'll stop here and move on to others.
Thank you, Prof. Zahid. You highlighted some issues with the identification of urban poor and the problems with the data and so on. So building on the experience of Prof. Zahid, may I now turn towards Dr. Osasui. What do you think are the drivers of inequities in terms of access to quality primary healthcare service in urban setting? Since you are expert on gender and intersections, would you please share your experience on that line? Over to you, Dr. Osasui.
Yeah, thank you so much for that very important question. So I kind of always like to reflect on the structure of urban settings first. So we have a lot of the structure of urban settings come from migration, and what happens is that you have people coming in, and they're coming in from a cultural context. They're coming in with vulnerabilities, and then they're mainly economic migrants. So they're also coming in and because they're looking for a source of livelihood. So that already kind of dimensions what this sort of drivers will look like. So first of all, you will have economic and financial barriers, because obviously they won't be able to afford the high cost of healthcare services in in urban settings. And then, of course, you would also have issues relating to how the urban health system is fragmented. It's set up. So there's a lot of health system fragmentation in urban settings. You don't have an equitable distribution of primary health and secondary health care centers in urban settings. And this would lead to issues relating to, for example, weak access to care, but then also weak referral systems. So if somebody needs to move from primary to secondary, that becomes difficult. Some areas will have a lot more, because of poor urban planning, have a lot more services than others. And then because there's a lot of rural urban migration, you tend to have a lot of informal settlements. A lot of these informal settlements do not actually have healthcare centers. So people have to rely a lot more on informal health workers. And we know that, I mean, I heard the presentation from Nigeria, you know, in terms of trying to upscale healthcare workers, informal healthcare workers. Without, you know, proper capacity, they're also not able to render services. And then we also have issues relating to workforce distribution. Even in urban areas, you still have an inequitable distribution of healthcare workers. So they'll be more concentrated in tertiary facilities. A lot of issues relating to brain drain. A lot of those primary healthcare centers on the fringes are mainly run by informal healthcare workers or auxiliary or workers. And then finally, you look at the broader social determinants of health. And so within this, you look at people coming, they don't have a job, so they don't have access to health insurance. They may have to rely more on out-of-pocket expenditure. And because also they're unemployed, they may not be able to get the sort of housing. So housing is substandard. That is also increasing the risk of, for example, communicable diseases and respiratory illnesses, issues relating to poor sanitation. All this would limit, you know, access to services. And then when you put all these things together, like I said, they're coming from a cultural context. So they are still subject to all the gender and cultural norms that limit access to services, services, and just that the basis of their cultural understanding of what healthcare access should look like. They may, for example, be more inclined to informal providers or even traditional birth attendants because that's what they were used to, you know, coming from, and all the general stigma that comes, for example, from accessing health care services with barriers for language and all that. So in a nutshell, this is it. Speaking a bit more to the gender dimensions, I think we can, if there's time, we can take that conversation later. Over.
Thank you, Dr. Osasui. You nicely highlighted the drivers of inequity for quality primary health care. You went us through different gaps in the health system, such as referral system, urban planning, capacity of the health system, limitation of health workforce, financial hardship, and so on. Now, of course, there are a lot of gaps in addressing inequity in the urban context. However, it is also good to note that urban health discourse seems to have gained momentum, and also some progress have been also made in the field. Now, I would like to ask Prof. Said, to your observation, how much progress do you think has been made towards USC in urban context? So what gains have been made to address inequity? Over to you, Prof. Said.
Yeah, thank you. Can you hear me?
Yeah, we can.
We can hear you. Thank you.
Oh, okay. Yeah, I am picking up two words from you, that there's progress and some dynamism or something that you referred to. But is it so? I mean, who are left behind? And
So,
we have some idea about who are left behind. Yeah.
Yeah, Prof. Said, please keep going. Thank you.
Yeah. So I think there are lots who are left behind, even when we talk make big talks about USC, even on this USC day, just one day before USC day. because there are people who don't only reside in the slums who are vulnerable. They are vulnerable, but slums is a mixed population. At least in Dhaka city and big cities, they are seeing that there are quite some people who are quite well off in the slums, but there are people who lives in the street dwellers, the beggar, the destitutes, people who are employed as scavenger. They scavengers all the day long, and there are some professions where risky population like shipbreaking. There are people who are keeping our towns and cities clean. So these are the people the most vulnerable and most marginalized, and unfortunately health system failed to reach them even in this 21st century, this month of USA Day, because they have systemic issues with accessing healthcare services from formal health system. Of course, government public health system, not to speak about that, they are sometimes stigmatized. They are not given due access. They are not dealt with respect and dignity. There are also financial problems. So there are lots of issues where they can't access the health service. Health services. We did a few studies on these street dwellers. Quite, I think before the COVID struck, and we found that usually these people, they don't go to the health facilities until and unless there is some accident, they are injured severely from some accident or some chronic illness which becomes life-threatening, like asthma or heart cardiovascular diseases. Usually what they do, the formal sector people, providers, starting from drug shop attendants to whatnot. So that's a big failure of the health system, that they can't reach them. There have been some attempts in a small scale in Bangladesh, at least in Dhaka city, where some pilot projects tried to reach these people through some innovative measures like taking healthcare to their doorstep through mobile health clinics and providing some essential health services, mostly free of cost, and linking them to so that if the illness is severe and they need a little higher level of care, so that they can access those services. So but most of these have been on a pilot scale, and it is to this to formalize in the formal health system and scaled up. So in Dhaka city, at least who are sleeping in the streets every night, it is more than 100,000. People have estimated something like 200,000 to 300,000 even. And if we consider all the big cities and the big towns, it will be, the number will be quite large. So on this day of ESC, I will say that I don't think we have reached the population that are in dire need of health services because of our systematic failure, and we really need to do something proactively with adequate resource allocation, with people motivated health projects at a scale so that it lies in the health system.
Thank you, Prof. Said. You really took us through the systematic issues that actually barring health system to ensure equity. Just I wanted to remind our audience, there is a QA button in the screen. You may post your questions if you have any. Now, may I ask Professor Peter, let's talk about if there is any progress in addressing inequity. we often talked about innovations, technology in healthcare. In your experience, are there any model innovations or interventions that have successfully helped urban health system to address urban health inequities, or have you seen any progress that has been taking place to address inequity in urban context? Over to you, Prof. Peter.
Thank you so much for this invitation to contribute to this important topic. We're talking about who gets left behind. Obviously, when we talk about the urban context, so many factors make some people to be left behind. Some of my colleagues and even the presenters have made some of these factors. But one good news is that technology is helping to bridge the gap by, number one, expanding access to healthcare. Through technological improvements, there is now increased access to healthcare services among people who previously did not have such access. Technology, for example, has been deployed in the area of telemedicine, which have made it easier to quickly and rapidly respond to healthcare challenges. Not only that, technology also has helped in the area of early detection and triage. A number of previously unknown or poorly diagnosed ailments have become properly diagnosed, and even precision solution and management have been made available because of improvements in technology. The healthcare workers also have benefited from technology. We now have platforms that help healthcare workers to better understand diseases, the nature of diseases, the pattern of diseases, the drivers of diseases, and so they can come up with more precise prescription to addressing healthcare challenges. Not only that, in terms of increasing equity and improving decision making, we now have a number of platforms that are helping to provide real-time information about disease burdens, about behavioral issues, about environmental conditions, which are helping vulnerable communities to take informed decisions, and also even government agencies or policy actors are able to come up with solutions that are very precise. ComCare, which is a mobile platform. We also have in South Africa what we call Mon Connect. It's an innovative approach that is addressing inequality in terms of healthcare delivery. In India, there's a program that the National Health Mission launched called Urban Health Program. This Urban Health Program has been is a very innovative approach which helps to bridge the gap between those who have access to healthcare and those who do not have access to healthcare. This has even been piloted in a place like Nkuru in Kenya to improve equity and also responses to healthcare problems. Let me talk about data. There are a lot of platforms that are also being developed to be able to help to improve
We've just lost Peter. We might have to come back to him. Shriman, do you want to carry on?
Oh, thank you, Prof. Peter. I'm sorry that you have been disconnected, Prof. Oh, sorry,
Yes,
we can hear you.
All right, so we have some initiatives today which are using integrated approach, bringing in census survey, household survey, earth observation, GIS, to provide data at the community level, which try to explain the pattern of disparity. We trying to also show the location of healthcare services in relation to people's dwelling units, and also to see the distance between residents and healthcare facilities. All of these are helping to improve healthcare access and also decision making. In this category, we have the one project that I'm involved in called Idea Map Data Ecosystem, which have provided platforms to characterize and to help to understand general healthcare model as well as emergency obstetrics to explain how women access maternal health care, whether and also to understand factors which limit their access to maternal health care. So all of these are helping for better service delivery, better improved decision making, and also healthcare access. There are also the role of citizens in collecting data, which are helping also to show, for example, the connection between air quality and healthcare condition, and which now helps healthcare workers to provide precision in a very precise way. Not only that, it also helps government officials to better plan infrastructure, whether in terms of open spaces or in terms of urban planning, where to site facilities to be able to help people to live and improve life and enjoy healthy, healthy living condition in their various neighborhood. I think I'll stop here for the sake of time. Thank you.
Thank you, Peter. You really highlighted some innovative technologies that are actually helping to bridge a gap in the healthcare in the context of West Africa. There are a lot of things to learn from your context, and of course, helpful for all of us. Thank you. Connecting to your response, I want to ask Dr. Deepak now. As we all know that public sector alone may not address all the gaps in universal health coverage. So how the city government can work with the stakeholders such as private sector and other non-state actors to strengthen urban health system? Since you have quite long experience of working with health system in Nepal, would you please highlight how stakeholders can collectively work to address inequity to achieve universal health coverage? Over to you, Dr. Deepak.
Thank you, Sriman and Chorus team, for providing this opportunity to share my perspective. And with regard to what is really needed to engage non-state actors like private, cooperatives, and other sectors, I think there are two things that we need to consider. So the first thing is openness from the public sector to engage them and not seeing them as competitors, but collaborators. We see sometimes public sector seeing them as competitor and not necessarily collaborator, and there's no openness to kind of really respect the service and acknowledge the service that the private sector or other sectors are also providing. So that is needed from the public sector, and from the private and other sector. They need to do their business more responsibly. We have seen a number of malpractices and very deteriorated quality of care or excessive use of antibiotics and lots of things from private sector as well. So there is responsibility of private sector to have a responsible business model so that they can deliver services as well as make profit, which is kind of their motive as well. So this is the first thing that I would like to kind of talk about. We all know, like in context of Nepal, in many urban setting, nearly half of the people go to private sector, especially private clinic or private pharmacies, as their first point of contact. We have seen that from the data from Harvard International Implemented Study by Chorus. Similar data is also there from Nepal Health Facility Survey and so on. So we really need to acknowledge that people are going there, and we need to understand why they are going there. So they are going there for a number of reasons, because the opening time is more convenient for them. The distance to some of these private outlets is kind of more accessible than the public institutions. They do have some trust issues with the public sector, because some of them do say that if I go to the public health post, there is no drug or there is no service provider, and I need to come back. Or even if I go there, the quality of drugs and supplies are not good, and I eventually have to come to this private clinic or private pharmacy to buy these again. So why to just waste my time? So there are issues like that people have reported in surveys, and we really need to kind of address those things, because that is one of the barriers. We have been talking this morning about why out-of-pocket expenditure, OP, is that high in Nepal, and where that is going to. And the data shows that most of the expenditure for OP is coming out from treatment of non-communicable diseases, and it's going to medicines and medical products. So we really need to kind of change that. We really need to make sure that not just rich and who can afford are only getting services, but also urban poor, marginalized, vulnerable people to also have access to this life-saving treatment and medication. So from that perspective, the private sector should be providing more quality services when they can. If they cannot provide those services, rather than just prescribing more, they should be linking those clients to the public sector. So there are some good models from the Global Fund funded projects. For example, the private sectors were trained to and requested to kind of collect sputum samples, and that was transported to the microscopy center, and based on the diagnosis, then they were kind of referred to the tuberculosis treatment center, than just providing different antibiotics and different drugs from the private medical shops and clinics. So I think we need to explore those kind of ways to really refer cases from public sector to private sector, private sector to public sector, when the services cannot be delivered in a quality manner, or people are really not utilizing those services. So that's my another point. The other thing is about making other private sectors, so not just limiting to private health sector, but private businesses, for example, because in many people in urban setting, they are suffering from a number of non-communicable diseases, and just treating them for those non-communicable diseases is not the way forward. We need to think from public health perspective, from prevention, health promotion perspective, and how can we engage businesses and private sector to have more enabling environment within their workspace, and then so that the employees can have better quality of life, better lifestyles, and so on. So there are some examples like having a workspace where people can kind of walk around, not just sit in their desks, and then they can also have flexible working hours, so that people can actually go and utilize healthcare services when needed. There are some good examples from COVID time. I'd just like to cite one. So when we were organizing a immunization camp for COVID-19, we collaborated with private sector and asked them to kind of shift their duty hours so that people can come and get their vaccination and then can go to their work and continue their work. So in that way, they can get health services and they can also have their business. Otherwise, because of the fear of losing business, they might not go to utilize health services. So we have seen lowering number of immunization coverage and family planning utilization in urban areas, and that is really concerning. And we really need to identify ways to make sure that people do have access to services. They can utilize it. Services are available at the time that they can access those services, and also kind of adapting our service hours, collaborating with private sector to shift their flexible working hours, or shifting some of the working time with the health service delivery time will be providing enabling environment for people to utilize health services, access health services that they are in need of, and at the same time not deprived from their job wages and that kind of thing. So we need to kind of consider their opportunity cost. We need to consider that many of them are actually living on daily wages. They do have fear of losing job if they don't show up at the work and those kind of stuff, and then really changing our health system. The other thing that I would like to talk about is really revisiting our healthcare delivery model, because in many urban areas, government and most of us do feel that, oh, there are good number of hospitals, clinics, and people can go and utilize services. But that is actually not true if we look at from the perspective of urban poor, migrant population who are very mobile in their nature, different minority groups like Dalits and gender minorities and so on. And then how can we reconfigure health system so that those services are also available? So sometimes establishing a clinic near the bus park might be very good, so that transport workers and people who travel can also get those services. So really thinking from the views of the urban poor and engaging them in this kind of processes. We rarely engage them in the planning process. We really engage them to get feedback about the healthcare system, but really engaging them in the policy making process, program planning and budgeting process, and understanding their needs, their requirements, their expectation, and adapting our healthcare delivery model to cater services also for them, and not just for the general population or not just for the other population, is the way to go forward. I'd like to kind of conclude by saying the statement that was quite discussed during COVID period. So no one is safe until everyone is safe. And we need to kind of educate our whole people that if there is a pocket of urban poor, urban slum who are not safe, who are not receiving services, just having good health services for others is not helping us, because the many diseases are kind of transmitted from them to us as well. So we really need to create a society where we can deliver services for everyone and everyone remains safe. That's the way we can protect health of every citizen living in the country, every people living in the city. I think because of time, I'll conclude my opinion here, but I'll be happy to kind of have further discussion in the days to come. Thank you.
Thank you, Deepak. You clearly explained the avenues of engaging diverse stakeholders, and you also presented some best examples from Nepal. I hope your examples will be definitely helpful for the health systems across different parts of the world. So I wanted to ask next round of questions to the panelists. However, it seems like time is not allowing us to do so. So I want to thank all the distinguished panelists for providing your valuable insights in urban health discourse and at achieving universal health coverage. And I also want to thank all the participants joining us from across different parts of the world. Now we are towards the end of the webinar. May I request Professor Irene from University of Ghana, who is also the CEO of Chorus Research Consortium, to wrap up the webinar series of Chorus and conclude.